I know, that was nice, thank you.
All right, so we're going to go on to the palliative and hospice care portion. We just got done with the home health care. So when we're talking about the palliative and hospice care, these are your objectives. Sorry, I forgot to pull my notes up over here. My computer, somehow when I shut it, it powered down, which it doesn't usually do when I close it. So we're going to talk about the different types of advanced directives. Different types of palliative care and end-of-life hospice care. Discuss the characteristics of hospice and end-of-life and caring for the patients and their dying patients and their significant others. Sorry, my computer's trying to tell me I have no internet over here, so I don't know what's going on. We're going to wing it with, yours is too?
Yeah.
All right, we'll wing it with no notes. Figure it's my thing anyway, so. Identify criteria for admission to hospice, describe the scope of services available, the barriers, and summarize the physical and psychosocial manifestations approaching death. Oh, there's more. Assess the importance of client culture and ethnicity when planning, providing, and evaluating care. Identify the way the nurses can assist the client in managing physical symptoms at the end of life. Analyze the spiritual needs of the dying patient and their families. Explain the stages of grief and bereavement at the end of life, and analyze the way an RN can assist the client and family in coping with the suffering, grief, loss, dying, and bereavement. So when we talk about advanced directives, what are our advanced directives? Pretty much three things are involved. Living wills, power of attorney, DNRs. Good. And what? Organ donation, yeah. So when we talk about a healthcare surrogate, we have a healthcare proxy and a healthcare surrogate, right? So when you designate someone as your healthcare surrogate, you're basically stating what? As once you become incapacitated and can no longer make your own decisions, they may make your medical decisions for you. So the difference between that and your power of attorney is that person who has power of attorney, now a healthcare surrogate form, you and I can fill out and sign with a witness, and that's great. Durable power of attorney has to be done through an attorney, and that's giving somebody the access to, if you become incapacitated, to get into your funds and pay for your car payment and your rent and whatever other things need to be done outside of your health care. So that would be running everything else in their life that needs to be done while they're in the hospital. A difference between what?
Having a financial power of attorney and a medical power of attorney?
So in Florida, we don't have a medical power of attorney. In Florida, we have the healthcare surrogate and healthcare proxy. The durable power of attorney in Florida is someone that you're going to designate. And when you do it, it's not just they don't automatically get everything. Basically, you say, I want this person to be able to do X, Y, and Z.
I was just curious because the social worker I worked with, she was very particular with new patients coming into the building, whether it was an actual financial or whether it was not.
Right. So I know I can only speak to Florida, but one of our instructors that just left was from Chicago. And in Chicago, the healthcare surrogate and proxy is the durable power of medical. Yeah.
And when my parents lived in both Wisconsin and Florida, we had them in both states because they were so different.
Right.
So, and we're just a family that's losing that. So, you really have to know where your parents are, where you know, how it works when you're not in your state and something happens.
Right. So the healthcare surrogate is me saying, if something happens to me, I want you to be my person who makes all my decisions. What's the difference between that and a healthcare proxy? Healthcare proxy is someone who is like from the state or from the hospital. When you have nobody there to do it for you, they're assigned to you. So they would make your decisions. What's a living will?
Something you write to
Specific instructions as to what you want done, right? So in Florida, one of the ones that when I did my research project in college, we had to go get our IRB approval and this and that. And one of the things that we used during ours was called the 5 wishes. And Florida is one of the 5 wishes states. It's a pamphlet, and it's about 6 pages long. And it goes through pretty much every situation that you could be in. And would you want this done? Would you want this done? Would you want this done? Anything other, write in your own response. So it's basically saying, let's say you got into an accident and the doctors determined you have 2 months left to live. Would you want us to, give you the stuff that you needed to live longer, tube feeds, whatever. So in your living will, you're just determining what exactly you do and don't want done if you come to the point where you're incapacitated and can't say, I don't want a feeding tube. Hopefully, whoever your healthcare surrogate is has also been involved in the decision, and you've had a talk with them, because there's nothing worse than, first of all, you want to make sure your healthcare surrogate knows that they're your healthcare surrogate, right? Mm-hmm. So you're sitting at home and you get a call and you're like, hey, Joe Schmo, you know Joe Schmo? And you're like, oh yeah, I worked with him like 3 jobs ago. Oh, well, you're his healthcare surrogate, and he's in the ER. You don't want that, right? You want to make sure that whoever's your healthcare surrogate knows, because you want to have these conversations with them, and when you want to make sure that they know what your wishes are, so that, let's say, for some reason, you decide that the fireproof box in your bedroom on the bottom of your closet, under all your clothes, is where your living will and DNR are, right? And you haven't talked to anybody about it. You think when EMS comes into your house, they're going to know to go under your clothes in your closet, find a key. No. So you want to make sure that there are other people that you've talked to about it. You want to make sure that if you have a DNR, that it's in plain sight, right? Back of the front door, the refrigerator, over your bed, wherever. That way they have it. And in the state of Florida, it has to be what? It has to be signed by a physician, but it has to be yellow. Who just said it? Someone, yeah. So it has to be on yellow paper. If it's not on yellow paper, it's not legal. You don't have to take it, the DNR. And now, most of the time when you see it, it's like DNRO, do not resuscitate order. But it's really important that the person that's making your decisions is on the same page as you. You don't want them to, you get to the hospital after a traumatic car accident and they have a copy of your living will, but they don't agree with anything you put in there, because you're 89 years old and decided that if you go in there, you don't want CPR, you don't want tube feedings, you don't want a ventilator. But it's your daughter who can't live without you, so she decides that she's not going to give them your living will, right? So you want to make sure that whoever you make your healthcare surrogate, that you really are on the same page so that they follow your wishes.
So they would use the living will over the healthcare surrogate, right?
Well, it would be both.
Yeah.
So, like, for hospice, the ones that hospice actually has, and the girl Tracy that'll come talk to you on Thursday, she goes over the advanced directives way more than I'm going to, but she has packets that she'll give you, and inside those packets are the hospice ones, and part of the hospice one is the healthcare surrogate. But it can be done separately. But your living will, your healthcare surrogate is your person. Your living will are your wishes, basically. Organ donation. Obviously, your decision is made by you. You have your license that says organ donor on it. Does that mean that your family has to let them do it? Doesn't mean that they have to let them do it. Hopefully, if you've made that decision, you've also talked to them about that and they're okay with it. Has anybody been in the hospital when a patient's passed away and you see they make all those calls and they call like the Lions for the eyes, and even if they're not organ donors, they have to call, or even if they have something that would preclude them from taking those organs, they still have to call. Lifelink, yeah. What's that? Lifelink? That's that too. That's right. Okay, so palliative care and end of life and hospice. So what are our goals of palliative care? Tell me, first of all, the difference between palliative care and hospice.
Comfort measures, and end of life is
So the difference is hospice, the patient can no longer be seeking curative treatment. Palliative care, if you have congestive heart failure, I can get palliative care to come out and work with you. Even, because that is a life-limiting disease eventually. But you can still be doing curative treatment. So let's say you have cancer and you're not quite ready to let go and you want to try some radiation because you think that it's going to help and that maybe you can get better. So I would call palliative care. They still are going to give you a lot of the same benefits as hospice. The only a few different things. They won't give you like the durable medical equipment. They will manage some of your medications. They do bill your insurance. So with hospice, they will treat you for years, even if you have no insurance. But the big differentiation is you cannot be seeking curative treatment in hospice. So once you do your radiation with palliative care and it doesn't work, and you decide I'm not going to do it anymore, then they will consult hospice, and hospice will come in and take you over. We want to get that patient and family to acknowledge that dying is a normal process. A lot of people, death is just one of those things that kind of scares everybody. So we need to work with the family a lot of the time for them to realize that this is a process, and once it starts, we can't stop it. You not getting hospice for your mom isn't going to keep her alive, right? Neither hasten nor postpone death. So as a hospice nurse, you always hear those stories. Oh, I gave the last dose of morphine. I think I killed them, right? Or the nurses are like, I don't want to give that much morphine. I don't want to be the one that kills them. We're not killing them. We don't hasten, the death. We keep them very comfortable while they're dying, but we're not killing our patients. We see the patient as a holistic patient, and we want to make sure that we're enhancing their quality of life. What does that mean? Yeah, so we have these patients who are dying. So if you were treated like a dying patient and kept in bed all day, every day, and just catered to, are you going to be happy? Probably not. Probably die pretty quick, right? But what if you really liked music, and so now I'm going to bring out my music therapy, and you guys are going to have kumbaya for an hour every day. Right. We do a lot of stuff outside of just caring for the patients as far as music therapy, art therapy. We have volunteers out the wazoo. Hospice is pretty much more volunteers than employees, and they go out and they do shopping for patients. They go and spend time with patients. They'll go and just play cards for an hour or two with them if that's what they want. So we try anything that the patient is interested in and is their thing. Like if they always went to every Thursday night they went to girls' night at Carrabba's, and now they can't go. So maybe we'll make a phone call to their friends and just say, hey, how about this week you guys come here and do it at their house. So we try and keep them as engaged as they possibly can be in their illness. No, that's the same thing. Live as actively as possible. Family members get, I think it's a year now, a year of bereavement after the patient passes away. If they're in hospice, they can get free bereavement services, so counseling, groups. Hospice has a ton of free groups as it is. At all their centers, groups, you can just come in from the public, like an AA meeting, but they're for, spouses who passed away, single parents now. They have tons of different groups, support groups. So what is hospice? I don't know, Miss Mistretta, what is it? It's a concept, not a place. Is your Wi-Fi back on, guys?
Mine's on.
It is? Mine says I have no access. Wait, give me a second. If it won't let me in that way. Oh, I can't get in that way either. All right. Focuses on what? Quality and comfort at the end of life. Usually is limited to the last, everybody should know this one, right? 6 months, right. Assists patients to live what do I have there? Right. Assist patients to live as active as possible. It includes symptom management, family care, spiritual care, and bereavement. Where do we provide most of our care? In the home. Good. And then the last one should have 2 lines actually, and it's just multidisciplinary. Oh, I'm in the wrong course. Hold on, give me a second. With the dossier, I have to pause it. I forgot. So, I'm not going to back that up. My notes over here, I just wanted to talk. So, services for hospice, are we just like 9 to 5? No, it's 24 hours, right? I can tell you, so one of the other things that I do besides going in and restarting people for their hospice is I do symptom management from home, just on the phone. And when I'm on call, I get called all day, all night, call after call after call. I mean, we have 1,300 patients, so I expect to be busy, but 2 o'clock in the morning, they're calling me. And so there's always a nurse there. If the family has some sort of crisis, they can call and someone will be out in a matter of, an hour probably, if not sooner. One of the other things that we do is we don't just serve the patients at their house, but when they sign on for hospice, they basically agree that if anything happens to call us instead of calling 911. That being said, we do have patients that are not DNRs. So depending on what's going on, 911 may still be called. And people still do call just because they especially non-medical folks, they kind of freak out, right? Don't know what to do, so they call 911. A lot of times, though, we can get them to call us instead, and then we have the hospice houses, which most of you will go to. The Bayfront floor that you guys are on is a hospice house as well, and that's basically a day to 2 weeks that they usually stay there, and we treat things that can't be treated at home. So let's say the patient has pain, and they've called me 6 times on that Sunday already, and no matter what I'm giving them, I can't give them a PCA pump while they're at home, so I'll have them come get the patient. They call transport, comes and gets the patient, puts them in the hospice house. They call me for admission orders. Now I can put that patient on a PCA pump. Once we get them under control and on a regimen that's working, we can actually send our patients home with PCA pumps. So then they'll go home and we'll manage it there, but you can't initiate it there. So I always say your patient's having COPD exacerbation. Just because a patient has hospice doesn't mean that we're not treating all their symptoms, right? We're still treating symptoms. We're just not doing curative. So your patient's having a COPD exacerbation, they go into the hospice house, we get nebulizers going, and this is stuff that we could probably do at home, but we can do it quicker if we can get them to the hospice house because we have everything and we don't need to order it and get it in the house. So we get that under control and then we get them home because the goal is really to keep them in their own home with their own surroundings with their own people to die a peaceful death. Yeah.
So if the patient has diabetes and like they have high blood sugar levels, we still give them insulin?
So it's going to depend on where they're at. If they're in a situation where they're finally at that point where we're saying their CMO and we're just kind of, we usually will take them off of any medications except for maybe some seizure meds. And usually they're not eating at that point, so we stop all their insulin and everything else.
Okay.
Yeah. But the goal is to keep them at home, so that way they can be surrounded by their family and their things, and it can be peaceful. Talked about the volunteers. Have any of you guys ever been in the hospice house? Have you had anybody there? Yeah. It's a pretty calming, like, it's a nice place, right? I mean, it's not like I don't want to die there, but if I have to go someplace to get treated for something, it's a pretty nice place. And I'll tell you, you are not going to meet anybody that's like a grumpy nurse or grumpy CNA at hospice. I've worked there for 2 years, and everybody you meet is always in a good mood. They're always smiling. They love their job. So it's a very nice environment that you're in. So as far as the unique characteristics to the end of life hospice care, oops, oh, wrong one. Again, we want to just make sure that we can keep their quality of life as much as we can. Freedom from pain. When I first started doing the symptom management, I just started doing it a few months ago. And I'll tell you, the amount of medication that we give a lot of these patients is unreal. Absolutely unreal. And the nurses call and they're like, oh, can we give this? And I'm like, it's a lot. And she's like, nope, you're fine. But that's the goal, right? I would rather keep a patient a little sedated and free from pain than have them screaming in their last hours of life because they're in pain, right? So we want to keep it as free from pain as we possibly can. Symptom management, again, just because your patient has hospice, we're not going to let them, if they have a UTI, we're going to treat their UTI. If they get pneumonia, we're going to treat the pneumonia, unless the family requests that we don't. And sometimes they will. They'll request, like, we're done, this is repeated, it keeps happening, we just want to stop and let nature take its course, and then that's what happens. Prepare them for death, so we'll talk about grieving in a minute, but we want to talk to them about their expectations, what they want, what the family expects. We want to warn, the family. We have this little blue book that we give the family. Has anybody had a family member in hospice? Did you guys get the little blue book? So I had a student a few semesters ago whose dad passed away the semester before, and she didn't look at that book until after he passed away. And she said, God, I wish I had looked at that book, because basically it went through everything, the modeling of the skin, the secretions, kind of just gives you a little warning, like, these are the signs and symptoms, this is what to expect. Patients, we don't give a lot for secretions generally. We use a lot of turning, laying them on their side, hopefully it'll drain, because the gurgly breathing isn't bothering the patient at all. It's the family that it bothers. But if we prepare the family and tell them to expect it and explain that the more we're going to treat the secretions, the more secretions they're going to make, they're going to be uncomfortable. We're going to do this and this instead. We can usually, work with the family. So we want to make sure that we're preparing not only the patient, but the family also. A sense of completion. What does that mean? Who? For me? Do I need a sense of completion? The patient, right? So you always hear the stories about that patient holding on to see that one last family member, and then she flew in from Boston, and then he died within an hour, right? So sometimes you just have to help them with that sense of completion. If, they keep talking about this one thing over and over and over, and sometimes, it's called life review. So they keep telling you the same story. When I was 18, I got enrolled in whatever, and you hear the same story over and over. And, the wife's going, oh, John, come on, give it a rest. We've heard this story 12 times. I'll sit there and listen to it 12 times. If they want to tell me 15 times, I'll listen to it 15 times, because it could be that was like their happiest moment in their whole entire life, and they just want to keep reliving it because that's what's making them happy and helping them to live on. In the hospital, it gets a little iffy because a lot of times we have way more patients than we should. And so if you have a patient who is hospice and they're passing away, sometimes there's no family at bedside, and I just feel horrible when it happens. So I will kind of delegate to my coworkers and kind of say like, hey, everything's quiet right now, but if these 2 rooms or 3 rooms, can you just watch for call lights and whatever, get me if there's an emergency. Same thing for you in these 3 rooms. I'm going to go sit with him. Sometimes you sitting with a patient and just talking to them will help them pass because they just don't want to pass alone. It's like a huge fear for people, right? You don't want to pass by yourself. You don't want to be lonely at the end of your life. Sometimes they need to apologize to someone for something that happened 15 years ago. And until they get a hold of that person to apologize, they're not going to have a peaceful, end. There's just, you can tell there's just something wrong. Even if they're not with it and they're kind of delusional, you can just tell, like, they keep talking about the same thing and they're just real restless. And sometimes it's just bringing in that person that they need to talk to. Decisions about treatment preferences. That's really up to the patient and the family. Again, sometimes they tell you, we're done. We don't want to treat anything. Like, he's been in the hospital for the last 3 weeks. We'll take them sometimes, especially at Bayfront. A lot of them are transfers from Bayfront Hospital to that wing. And at that point, they'll put them CMO. And basically, like, when I get the phone call and they start telling me about the patient, my first question is always, are they a DNR? Right? Like I said, we have patients that aren't DNRs. Are there any allergies? What's their goal? Do I need to keep them lucid, get them better, get them home? Or is their goal to decline and die, decline and pass? And you'll hear that when you're at the hospice house. Their goal here is to decline and pass. Sometimes the family is not all about bringing them home to let them pass. They're not comfortable with that, so they'll stay at the hospice house until they pass. Hospice criteria. Another big thing is with hospice, your patient has to desire services. You cannot give hospice services to someone who does not want it. Home health care, I'm not going to let you go home as a provider unless you have home health care if you just broke your hip and you can't walk. Hospice, I can't tell you you have to have hospice. You have to want hospice. Does that mean if the patient's incompetent and can't speak, I can't give them hospice? No, because that's going to go on to the family member, right? So the family member is going to. Getting people to take hospice, like that lady said in the video, is sometimes very frustrating. I remember I was telling them up here, I have a 28-year-old stepdaughter. She called me a few years ago. Her grandma was passing away on her mom's side. And she said, I'm having a really hard time. They won't let me bring in hospice. They think that that's me giving up on her. Because none of them were medical. And so they thought, like that lady said, you're calling hospice. That means you're giving up on her. You want her to die. No. I had the same situation last fall with my grandfather. They moved here in July. In August, he got really sick and ended up in the hospital. He ended up passing away on October 12th. From August, I kept saying, we need hospice care. His primary doctor wouldn't get hospice. Like, he didn't want hospice. By the time I finally just went above his head and called hospice, I actually called palliative care. They said, oh, it's too late for us. You definitely need hospice. By the time we got hospice in there, he passed away the next day because not only was my grandmother fighting it, but of course the doctor was fighting it. Because like she said, the doctors, their goal is to save patients. So a lot of times in the hospital, I've had it happen where like me and one of the residents would be like, we need to do a hospice consult on this patient. And the doctor's like, no, let me try this one thing. Like they want to keep trying because that's what they're trained to do. I need to save this patient. That's what my Hippocratic Oath said. I need to save this patient, right? So a lot of times it's a lot of not conflict yelling, but you're just like, okay, so you have to kind of sit back, or you have a family member that just absolutely refuses. Couple stories. So one, I had this lady who was obviously imminent, and her 2 daughters were there, and they called her primary physician, who did not have services at St. Pete Gen when I worked there. And he said to them, take her oxygen off. She'll just die in 24 hours anyway. You don't want to go through the trouble of getting her in hospice. Myself and the resident were so upset, but we can't push hospice on somebody. So we had to sit there and watch this whole thing. It was horrible because, we tried explaining, like, it's not only for the patient, but you as a family member, you get a lot of benefits. You'll have counselors, you'll have people helping you, you'll have, you can take her home for her last 24 hours and, they'll give you anything you need at home. But a lot of people just they're very weird about hospice, and the doctors can be too. The other thing is the patient has to meet the eligibility requirement of having 6. Oh, I never switched you guys back over to this one. That doesn't matter though. 6 hours or 6 months 6 months or less to live. So does that mean that every one of our patients dies within 6 months? No, I see patients who are in like their 26th benefit period. So their first benefit period is 6 months. After that, every 2 months is a new benefit period because we have to recertify them every 2 months after 6 months, every 60 days. So we have patients that have been with us for like 5 years. We have patients that have been with us for a long time. We finally say, listen, you're not really declining, because that's my job as the nurse practitioner. I go out and I find some sort of decline going on. Every once in a while I'll get out and the patient is doing wonderful. They've gained weight. They're out, walking, and you're like, whoa, you've made quite the turnaround here. So we'll take them off hospice services. And most of the time within a few months they come back to us. But we have to prove some sort of decline to keep them on for another benefit period after 6 months. Who are the 2 doctors that can certify? Any doctors, right? So if you decide that your mom needs hospice, you can call hospice. One of our docs will come out, and then or one of our nurses will come out, talk to the doc, and then they'll call the primary care and get the primary care. They'll talk to them and get them to certify. A lot of times it's the family doctor or, the doctor at the hospital that will refer. Either the family asks or they just say to the family, there's nothing else we can do. And then the hospice doctor is usually the second doctor. So it's not 2 doctors outside. You don't have to drag your mom around to different doctors getting all these certifications. Our hospice doctor is usually the second certifying doctor. Hospice, we will bring out your every durable medical supply that you need. Beds, wheelchairs, bedside commodes, walkers, like you name it, we'll get it for you. The other thing that we'll do is we'll handle all of their meds that are related to that diagnosis or any diagnoses that are related to the primary diagnosis. Some of the things that we won't do is like if the patient's on, hospice for everything I'm thinking of course, is related to the other one I was going to use. Anyway, if they have like blood thinners, but it's not related to their primary hospice diagnosis and it's related to something different, then we won't pay for those. They'll still be responsible to get those from their pharmacy. But pretty much most of the time, 90% of the meds we're covering. And again, these patients might not even have insurance because we take them with no insurance. Even we will go see Joe Schmo living under the bridge at 54 Avenue South. If that's what he puts down as his primary address, we're going to go there and we're going to see him. So they'll also give any hygiene supplies, diapers, chucks, all the creams and lotions that you have at the hospital. Oh, I'm not moving my other one forward. Sorry, guys. Of course, the short-term inpatient care that we talked about. As far as interdisciplinary care, that's a list of all of the different people that we have on our service. And there's probably more. But as far as like PT, OT, music therapy is a big one. They call it SSC, the spiritual something coordinators. They stopped calling them chaplains because people zoned in on the word and thought that it was a religious thing. So now they are the spiritual care coordinators, and they will go out there and they will be whatever they need them to be. And you guys who are going to the hospice houses, like as a group, usually one of them will come and talk to you. One of the doctors will come and talk to you. That's the only downfall to us going to Bayfront, is that we don't get that little bit of it. But it's really interesting to hear, them say if they are Catholic and they want the last rites or whatever it is, like, we're going to make that happen. But if they're, whatever, they're going to do whatever they need to do. If they're not religious and they just want to sit there and they want to do yoga breathing, we'll do that with them. So they're just like an all-encompassing. They're a huge part of our team. Barriers to hospice care. I think that the statistics are that I'm going to say at least 70% of our patients are Caucasian English-speaking patients. Depending on where you are, your patient load might be a little bit higher, depending on the neighborhood that you're in. So our teams are cut in colors. So it's like gold team, red team, whatever team. And those nurses in that team work in just that area of the county. I work the entire county because I'm PRN, so I just kind of go all over. But so those nurses in each neighborhood, depending on what neighborhood they're in, might have a really high population of Vietnamese. So, they might be a little more up on the rituals and cultural parts to those patients. And they can probably, help those patients more than I could going into that situation. Definitely underutilized by minorities. A lot of the different ethnic groups have their own beliefs, and some of the beliefs are that you take care of your own. Why do I need hospice? I'm here, my family's here, this is what we're supposed to do. This is what we all should do, right? But we don't treat our elderly the way that we should in this country. So a lot of them don't want to bring hospice in because they think it's their job, they have to do it, which is fine if that's their belief. Lack of knowledge goes right back to people just don't understand hospice. They don't understand what it is. They really truly believe that if you're going to put somebody on hospice, that they are on their way out the door, and that you're stopping everything. You're not going to treat anything. You're going to let them just lay there and die. So it's a lot of education with the general public. And vulnerable populations also do not use hospice care as much as the general population. So when we talk about physical and psychosocial manifestations, we're going to look at this chart. This is from one of the older books, so it's not table 11, 12 in yours. It's going to be a different table in your 10th edition, I think, unless I changed it out. Hearing, last sentence to go, right? So when you have a patient and they're in the ICU and they are intubated, we usually say, like, they probably can hear everything that we're saying or doing, right? So if you have a patient, and I'm not just hospice, like a patient who's at end of life, and they appear to be comatose, they're not with it, they're gurgling and mottled, and you think they're pretty much on the way out. Do you think that they can't hear you? They probably can. So I had this guy, I was at St. Pete Gen, any of you guys who have been there, that third floor nurses station in that room right there, so I don't know, 318 or whatever that is, 321. And it was an older gentleman, and his wife and daughter came in, and he was imminent. So his daughter came out and says, "Jen, can I borrow your stethoscope?" I'm like, "Oh, okay." And she said, "I think Dad's gone." So the wife was in there just screaming, "No, Jen, no!" I guess she thought, like, that's going to make it real. She's going to come in and we're going to say it. So they have their time with the patient, and, they finally leave, and I go in to do postmortem care, and he has, like, a tear sitting right here. And I thought, oh, that poor man, like, as he was dying, he heard his wife screaming and upset. It was, like, the saddest thing ever. And I'll tell you that when you have a patient die, you're pretty much going to remember their faces. Most of them, if you've been with them for any amount of time. And any postmortem care that you do, you'll probably remember them too. So as far as other things that happen, what are some of the big things that you guys have seen happen? Anybody who's been on the floor when a patient's been passing away, like things visually even. Nobody has seen patients passing away?
Don't they like expel air from their body and then they like groan as they do it after they pass away?
Sometimes, yeah, especially when you turn them, yeah. No, but I'm talking about like while they're imminent, when they're laying there, they're still alive. What are some of the things physically that you see on them? What do they look like? They can have incontinence. They're changing breathing patterns, so sometimes they'll have some apneic, right? What's that?
The vital signs change.
The vital signs change. What do the vital signs usually do?
It's according
And then it
to
starts to
go up
go.
or
Correct. So usually, that's the body trying to compensate, right? Like it's failing, so your heart says, oh, I gotta pump a little bit harder, and your blood pressure goes up a little. So then the family's like, oh, look, but their blood pressure is up and their heart rate's back up. Usually it's not very long before it just is gone. What about some other visual things? What does their skin look like? What's modeling? What does that look like? It does. It kind of looks like a spider web, right? Like a thicker spider web, but like the purple lines and blotchy is all over. Usually it's the legs first. So you'll see a nurse getting a report, and they're like, oh, patient in 302 is not doing too well. He's probably on his way out the door. They'll go in the room and lift up and look at their legs and feet, because that's usually one of the first things, besides other things that you're looking at on your monitor. A lot of times the legs and feet. And why is that? Shunting blood, right? So it's trying to keep blood going to the brain, the lungs, and the heart, right? So it's not putting blood out to the peripheral anymore.
Sometimes there's the discoloration on the back of the...
Right, so the pooling, yeah, so the pooling, so that's kind of the same thing as the modeling, yeah.
It looks different though.
It does. What else does their skin look like? It usually looks like, yeah, it gets a little cyanotic, really pale and gray and waxy, right? Sometimes they get the excess secretion, so they're real gurgly. Sometimes that doesn't happen at all, but usually in the last couple days, once they start gurgling, we usually know it's just a couple more days, if not a couple hours. Do they start putting out lots of urine? No, same reason, right? They're shunting the blood, so that's not going to the kidneys. They're not making urine anymore. That being said, my grandfather made urine till the morning he died, like bags and bags of it. So not everybody, but we talked about the breathing, modeling, cold, clammy skin. Those are the big ones that you're gonna see. Psychosocial. So remember we talked about that life review. They want to just tell you about all these stories, and maybe they think that you're their childhood friend and they're reliving all of your memories together. Peacefulness. Some patients get very peaceful at the end. Some families get very peaceful. Sometimes it's the exact opposite. Families get real rowdy. All of a sudden you have 20 people in the room, but that's usually like a cultural thing. They're there, they're supporting, and then there are other families that don't want anything. They, Dad's passing away, we're gonna leave. You just call us and let us know when it happens. And you're like, yes, that happens. Sometimes they get super restless, so we use a lot of Seroquel and Haldol and phenobarb. Again, the saying goodbye. Sometimes there's just that person they need to talk to. Sometimes all of a sudden, you'll see the patients that they suddenly, it's like they know, and so they start, this is probably gonna be the last time we see each other, and you're like, what happened between today and yesterday? But sometimes they just know. Vision-like experiences, so maybe they start talking to people who died years ago. That's a big one, right? And that might not necessarily be the very end of life. That could be the last few months. Suddenly they're having these hallucinations of their sister who died when they were 12, and they're talking to her and they're telling you what she's saying. And some patients become very withdrawn. They don't want they'll say, I don't want anyone visiting me, just have them all go home, leave me alone. Altered decision making, their anxiety with the unfinished business, which we talked about. Fear of loneliness, again, I don't know about you, but that's, I don't want to be laying there by myself with nobody around me, like, I don't know. Fear of meaninglessness. So sometimes they get really, they just keep telling you, like, oh my God, I should have. So it's you talking them through, it's okay that you didn't. And, everything happens, and making peace with them for this thing that they think didn't happen that should have happened. I can't believe I never had kids, and on and on and on and on. Fear of pain, which hopefully we keep our patients pretty pain-free. And then helplessness. You have that old stoic guy laying in that bed who doesn't want anybody doing anything for them. They want to do it all themselves. And then they get to the point where suddenly they're incontinent and you're cleaning them. And that's a huge deal for some of them. And, you just have to make it a normal thing. And, you know, if they start talking to you about it, talking to them about how this is my job. If I didn't, you know, expect to do this, I wouldn't have this job. And sometimes it becomes quite an issue with some of, especially the men. Client culture, ethnicity, when you're planning and providing and evaluating care, we kind of talked about that. You just kind of have to know your population that you're working with and know, like, in St. Pete, what your big populations are. If you're working at, you know, a hospital here on this side of town in North Side, there's a huge Vietnamese culture here in the Pinellas Park North Side area. Just knowing kind of where you're working and who you're working with. Am I right? I see you giggling. There really is, though. Let's see. As far as the stages of grief, I know you guys went through these in psych, right? No? Yes? Okay. So denial. No, this can't be. I don't have cancer. I'm not dying. This can't happen to me, right? Anger and bargaining. Now they've actually accepted it, not truly accepted it, but now, like, why? Why did this happen? What did I do? Well, why do I deserve this? What did I do to deserve this? Depression. Now, you know, there's not quite acceptance yet, but they're accepted the fact that it's there, and they're really, like, super depressed about it. And then true acceptance is when they turn it around and they say, you know what? It is what it is, and I'm going to do what I need to do and keep going on and make sure that I'm living my life the way I'm supposed to. Dad passed away, but, you know, I still need to live my life. All right. How can the nurse assist the client and family in coping with suffering, grief, loss, dying, and bereavement? How can you assist your patient and family?
By discussing it with them.
Yeah, by talking about with them.
Just by talking to them.
By talking to them, by telling them it's okay to be bad. It's okay to be sad. It's okay to cry. It's, you know, it's okay. So it's just basically having that, and like I said, with hospice, the family members all get a year of bereavement services. So the social workers and spiritual coordinators they'll call and they'll follow up and they'll go out to the house and meet with them and, you know, do whatever they can to help them in their bereavement. All right, so I got a couple questions for you. The husband and daughter of a Hispanic woman dying from pancreatic cancer refused to consider using hospice care. So what should you do? Can you guys see all that all the way back there? Number one, you want to clarify that they understand what services are being offered to them. And then if they still, then we are going to accept their decision and let them, you know, if they believe I just need to take care of my own, that's fine. But we want to make sure that there is no lack of understanding. And if their English is a second language, we would get an interpreter to come and help them understand what's going on and what we're actually offering. Terminally ill patients, unresponsive and has the Cheney-Stokes respiration. Patient's husband and grown children are arguing at the bedside about where the patient's funeral is going to be held. What should we do? You guys think too? Yeah, so take them aside and explain that to them. And then if they're still fighting, then I would ask them to leave or at least step outside because it's just not cohesive with a peaceful passing. Terminally ill man tells the nurse, I never believed there's a God or afterlife, but now it's too terrible to imagine that I won't exist. So why was I here in the first place? So the nurse recognizes that the patient is what? I hear people mumbling one. One. So we call that spiritual distress. And, you know, we'll talk to them, but then we'll also call in those other people on the team that can help with that. Patients in the last stages of life, they're experiencing shortness of breath and air hunger. What is the most appropriate action by the nurse? 4. We want to do whatever we can to make them comfortable. We want to give them the bronchodilators. We want to give them oxygen. We want to give them some anti-anxiety meds. End-of-life palliative care nursing involves what? Four? Encouraging the patient and the family members to verbalize their feelings of sadness, loss, and forgiveness. What's the primary purpose of hospice?
Well, it's not curative, so making the patient comfortable as much as possible.
4, right? Provide comfort and support. Sorry, I got a 6-7-year-old at home. My husband was just texting me. Good. So we're going to provide comfort and support for the dying families. So that's the end of the hospice, home health, and end of life. So tell me questions. A lot of the stuff you're going to get repeated on Thursday when Empath comes out. They're going to go a little bit more into things, more specific to their policies. The girl Tracy who comes out does the advanced directives. She's amazing, and she's a little ball of energy, so she's fun to watch.
So what's the difference in the end-of-life palliative care versus the hospice? So you said the palliative is curative, but...
Right, so with palliative care, you can still have curative, and it doesn't have to be 6 months. It just has to eventually be a disease process that eventually will end your life, right? So if you have hypertension, it's eventually going, we can get you palliative care for hypertension. Empath, the people that are coming out that I work with, they've been in the area for about 40 years, and they're nonprofit. There's a new hospice that just moved in the area called Seasons. They're for-profit. I don't really know much about them. But we have a palliative team. So under the umbrella of Empath Health, we have Suncoast Hospice, we have Epic, we have palliative care, we have lots of different programs. So the palliative team, even though it's, the doctors and nurse practitioners, when we have our medical staff meetings, the whatever Friday of the month, we're all there, but we have different teams. So they basically will take care of that patient, and remember, they only see patients who have insurance. But they'll basically care for those patients until they can pass them over to us, or the patient doesn't want services anymore. But does that mean that if you have a patient with cancer and they're doing radiation to shrink the tumor because it's a tumor next to the heart and it's causing decreased cardiac output, does that mean that they can't have that radiation to shrink that tumor and have hospice? No, because we're not doing it for curative reasons. We're doing it for palliative reasons, meaning we're doing it to shrink that tumor, knowing that the tumor is not going to go away, but it's going to provide some comfort for the patient. So when you hear a patient is on chemo, or not chemo, like radiation, and they're hospice, and you're like, it's being done palliatively. But I really love hospice. I don't know if anybody in here has ever worked for hospice as a volunteer or a CNA or anything, home health aide. They're pretty amazing. Okay, so no more questions about that stuff? You guys want to take a quick little 10-minute potty break? Everybody's coffee and everything they drank on dinner is kicking in.